peaceful rest last night. Yesterday, we had a very good time with Professor Alex Okotu on genetics of sickle cell disease. We all believe that it was very educative, interesting, and impactful. So today, we are continuing our series of lectures on this training with laboratory section. And also, we're also going to have for today, our first lecture for today is on laboratory section. The topic for today's lecture is hemoglobin electrophoresis and testing. Hemoglobin electrophoresis and testing. And our speaker for today is Dr. Eunice Ahmed. She's already with us. Dr. Agyeman, you are welcome. You are welcome, ma'am.
Thank you very much.
As a way of introduction, Dr. Mrs. Eunice Ahmed is a hematologist and the head of the clinical hematology unit at Komfo Anoko Teaching Hospital in Kumasi, Ghana. She obtained her medical degree at the Kwame Nkrumah University of Science and Technology, KNST, Kumasi in 2012. Following this, she pursued specialized training as a hematologist and transfusion medicine specialist at the Ghana College of Physicians and Surgeons in Accra, completing her training in 2018. Currently, she's pursuing a PhD in global health at Liverpool School of Tropical Medicine, LSTM, UK, focusing her research on sickle cell disease. Dr. Ahmed is deeply committed to enhancing sickle cell disease care in Ghana, actively participating in various advocacy, education, training, and research initiatives. Sir, Ma, we are so delighted to have you this morning with us. In addition to her clinical and research commitments, Dr. Ahmed lectures on part-time basis at the School of Medical Sciences, KNUST, and the Faculty of Pharmacology at the Ghana College of Nurses and Midwives. So please, let us listen, pay attention as Dr. Ahmed take us through one of the sessions in our laboratory, one of the topics in our laboratory sessions. So please, Dr. Ahmed, you are welcome.
All right, thank you so much for that introduction, and good morning to everyone. Can I go ahead and share my slides, please?
Yes, please go ahead.
Yes, ma'am.
Please, can you see my slides?
Yes, I can.
Yes, we can see.
All right, great. So thank you again for the opportunity to facilitate this laboratory session on hemoglobin electrophoresis. I've already been introduced. Again, I'm Eunice Ahmed in Kumasi, Ghana. Okay, so by way of introduction, I believe now we all understand we are at the same level when it comes to what sickle cell disease is. But just as a reminder, we know that it's a disease of the blood, particularly affecting hemoglobin. And hemoglobin is a specialized type of protein that is contained in our red blood cells. And its main function is to transport oxygen around the body. Okay, and we know that sickle cell disease is an inherited disease, okay, and its inheritance is autosomal recessive. And what this means is that you need two abnormal genes to be able to manifest the disease or to be able to express the disease. And sickle cell disease, we know it's most prevalent in sub-Saharan Africa, where we have the highest burden of the disease. Okay, so why do we have to test for sickle cell disease? So we do this basically for two main reasons: to screen and then to make a diagnosis. So when we say screening, it's mostly testing healthy individuals to see whether they have the disease or possibly even their career or whether they are carriers of the disease. And this is what is employed in the newborn screening. So when a child is born, the child will not show any signs of the disease, but you still want to test, especially in high burden areas, to be able to identify which of the children has sickle cell disease and which ones don't. Okay. Another way you want to, another type of screening is for couples who are planning to get married. Okay, because we know that children who are born out of a marriage partnership can have sickle cell disease if the parents carry these abnormal genes. So that's another opportunity to screen for the disease. Or couples who want to embark on a pregnancy journey. And then also the third point is for individuals or relatives of individuals who have sickle cell disease. So once you diagnose someone with sickle cell disease, because it's an inherited disease, you want to test the siblings, the parents, to be able to detect who has the gene or who is a carrier of the gene and who has the disease that may have gone unnoticed. Okay, and now when it comes to the diagnostic purpose, we use testing to identify individuals who may present with either signs and symptoms of sickle cell disease or anything that potentially looks like it. So patients who may come in with low blood levels or what we call anemia, people who have jaundice, that is when they have yellowish discoloration of the eyes and the skin, people who have recurring bone pain, okay, or in the circumstance where you request a peripheral blood film, which is a type of test which examines an individual's blood cells. And then you see some abnormal changes, which could suggest that the person could have sickle cell disease. So you go ahead to request this test to be able to make a diagnosis. Or someone who tests positive for sickle cell disease on the sickling slide test. You know, there's a sickling test where we tend to say it's positive or negative. So if someone tests positive for the sickling test, you want to go further to establish whether they have disease or they are only carriers. Okay, so looking at the laboratory tests for sickle cell disease, there are various methods. I've grouped them under hemoglobin tests. So these tests basically help us identify the types of hemoglobin that is present in an individual. And there are the rapid tests. The rapid tests are often useful under emergency circumstances. So when you have a patient you are managing, you need to establish whether they could have sickle cell disease or not. Use these rapid tests. But later on, you need to confirm with a more definitive testing method. Okay. And then there are the DNA-based tests. So the DNA-based test is a more advanced test that helps us identify or diagnose the disease at the genetic level. So this tells us the mutations that have occurred at the genetic level. So that is if the person has a disease. So it tells you at the genetic level that this person has hemoglobin AA, or they have a mutation that has resulted in an S or a C or any of the other variant hemoglobins. Okay, so my job today is to mostly talk about hemoglobin electrophoresis, which falls under the hemoglobin test that I'm talking about. Okay, so when it comes to testing for hemoglobin, there are also a number of testing methods. Okay, the first one, and that is the one that I'll be focusing more on, is the hemoglobin electrophoresis. And this is the most widely used testing method in our setting, and it's also relatively inexpensive, and it's able to help in the diagnosis of sickle cell and its various and the other variants. Okay, there are other testing methods like the isoelectric focusing, which at least I know in Ghana is used in the newborn screening program. There's also the capillary electrophoresis test, and then there's a high performance liquid chromatography test. Okay, so the lower three that I've just mentioned, they also can tell you about the hemoglobins that are present in an individual. But in addition, they can also quantify the hemoglobin. So it can tell you that beyond the person having, let's say, hemoglobin A and S, it can tell you how much A it has. So let's say 60% A and then 40% S. And that means that the person has a carrier, has a carrier status. Okay. So the lower three, its advantage is that it not only identifies, but it also quantifies the hemoglobin. Okay. All right, so before I go down the lane of the hemoglobin electrophoresis test, I'll talk a little bit about hemoglobin. So for the purpose of those who have forgotten or don't know what hemoglobin is, hemoglobin is a polypeptide, or we can call it a protein, okay? And it is found in a red blood cell. So it's a protein found inside the red blood cell. It's got 4 polypeptide chains. So this is one chain, another, and then the last one. And at the center of the polypeptide chain is heme. And heme is the ion-containing moiety. That is where the oxygen is carried. So the oxygen will bind to heme, and then it will be carried around the body and delivered to every tissue or cell. Okay, so what are the types of hemoglobin that are known? So there are many, many, many types of hemoglobin that have been identified, okay? But they are the ones that are very common, and those are the ones that we'll be focusing on. So there's hemoglobin A, which tends to have 2 alpha chains and 2 beta chains, okay? And hemoglobin S, which is, if I should call it a hemoglobin A, that has undergone a mutation. Okay, there's been a switch in one of the proteins along the chains, okay? Same as hemoglobin C's. There's also a mutation that has occurred there. That is why you have now a different type of hemoglobin called C. And the hemoglobin F is known as fetal hemoglobin. That is a hemoglobin that is present in the fetus. So as a child is or baby is developing in the mother's womb, that is the predominant hemoglobin that is present. And when the child is born, they still have a good amount of the hemoglobin F. But as they grow, it begins to reduce or decline, and then it's replaced with the adult hemoglobin, which is hemoglobin A. As I said, there are many others that we'll not be discussing in this session. Okay, so this is also to shed light on the different types of hemoglobin you may find in a normal adult and in a normal child. Okay, so in a normal adult, we expect that they would have predominantly hemoglobin A, between 95 to 98%. And then also there's a small amount of hemoglobin A2 that is present in an adult, okay, but usually it does not exceed 3%. And normal adults also have some baby hemoglobin, or the hemoglobin F, as they call it. Okay, but it's also very small. It's a small percentage. Usually does not exceed 2%. And you don't expect to find hemoglobin S, hemoglobin C, or any other variant or abnormal hemoglobins in a normal adult. And in a normal child, I've categorized them to the newborn under 6 months and beyond 6 months, okay? So you may find a bit more hemoglobin F in a child than you would find in an adult. And especially in the newborn period, when they have the highest level of hemoglobin F, and it can go up to 80%, okay? And as they grow through the 3rd to 6th month, that is when the decline, that's when there's a lot of decline of the hemoglobin F. And beyond the 6th month, the child will now assume the same components of hemoglobin as a normal adult, okay? So here they have very little hemoglobin F, as you'd see in an adult. That is beyond 6 months. Okay, now to the testing method, hemoglobin electrophoresis, and that's our topic for the day. So hemoglobin electrophoresis simply means a method by which we separate hemoglobins and identify the different types that are present in an individual. So we are doing two things. We are separating the hemoglobins and then we identify them. Okay. And when it comes to the separation, we are separating these hemoglobins based on a particular characteristic of hemoglobin. So hemoglobin has a charge on it. Okay. So when you subject this hemoglobin to an electrical field, okay, it moves from one end to the other. It moves from the negatively charged end to the positively charged end because the hemoglobin carries a negative charge. And we know that unlike attract, so the negative will be attracted to the positive end. And the rate at which the hemoglobin will migrate will depend on the strength of its charge. So if you have a stronger charge, you'll move faster towards the positive charge end. And you have a weaker charge, you move a bit more slowly. Okay. And this testing method can help us identify the sickle cell traits, that is the AS. It can help us identify the sickle cell disease, like the SS or the SC variant, and some other forms. Okay, so there are two ways by which you can conduct electrophoresis, hemoglobin electrophoresis. There's a cellulose acetate method and there's a citrate agar. I'll not bore you with all the terminologies because I don't think that is the focus of this presentation. But this is just to note that there are other methods under the hemoglobin electrophoresis. And the one we commonly use is the cellulose acetate, okay? And that is at an alkaline pH, and then the citrate agar is at an acid pH. Okay, so the one we commonly use is able to resolve most of the common hemoglobin variants that is available in our setting. Okay, and its downside is that sometimes it cannot distinguish between some hemoglobins that may migrate together. Okay, I'll explain this in my later slide. Okay, so just to take us back a little bit, before you order a test for hemoglobin electrophoresis, what sample do you take and what sample tube do you collect it in? So we tend to use the purple top tube or the EDTA tube. Okay, so that is where your sample is put in, and this is supposed to help prevent clotting of the sample. Okay, so once the blood sample reaches the lab, okay, the laboratory personnel will take the sample through a series of testing processes before we get a report. And this is just to also let you know how the electrophoresis, hemoglobin electrophoresis works. Okay, so this is a simplified image just to demonstrate this. So there's a power supply and there's the electrophoretic tank. Okay, and the tank contains the buffer, which has the alkaline pH. Okay, and these are the wells where the samples will be applied. These are the electrodes. So the electrodes, there are two of them. There's a negatively charged one and the positively charged one. Remember, I said hemoglobin has a negative charge. So when you apply it on the end of the negatively charged electrode, it moves towards the positive side. And this is the medium that will be used in the blue plate, if I should say. Okay, so the hemoglobin will travel from this direction towards that direction. And the rate of migration, as I said, depends on the strength of the charge. So we have ones that migrate very fast and then ones that migrate very slowly. Okay, so now let's look at the right side of the slide. Okay, so the negative charge is called the cathode and the positive side is called the anode. So we apply the sample here and then it migrates in this fashion. You can tell that hemoglobin A is in a comfortable lead. It's the fastest hemoglobin in this instance. Okay, so it tends to migrate the fastest. So it forms a band, a distinct band here. And this is closely followed by hemoglobin F. It also forms a band here. And then there's another batch of hemoglobins that will form in this region. And this could be hemoglobin S, D, G, or L. Okay. And then the last or the slowest will be these hemoglobins, hemoglobin C, A2, E, O. Okay. So these ones migrate together. So sometimes when you find a band here, it may not always be easy to say that this is indeed an S or D. But one thing that can help us is based on the common hemoglobins that you find in a particular setting, you can make a prediction that, okay, this is likely to be an S or a D, for instance. Okay. All right, so we've done our separation. Now we are going on to identifying the type of hemoglobin. So this is an electrophoretic strip, okay? And these are the sample wells, the blue plates. Okay, so there's a paper that will be generated from this. So these are the points of application of your sample, okay? And so this will be sample 1, sample 2, sample 3, okay? And anytime you do hemoglobin electrophoresis, you also run a control alongside. And the control is just to help guide us as to where you expect the hemoglobin bands to form. So these are control samples. Okay, that was run. And the control usually contains all the common hemoglobins in that population. So here is where your C will form. Here is where your S will form. Here is where your F will form in A. So it guides us to know where your patient sample has formed. Okay, so now let's look at patient 1. We can tell that he's formed a very thick band in the A region, okay, and a very faint band in this region, and most likely it's an A2, if you remember the composition of hemoglobin in an adult on my previous slide. So this looks like an interpretation for a normal adult. And then let's look at patient 2. We have a band forming in the A region as well as another in the F, but the F looks a bit more dense than one in the A region. So this looks like one that will fit a newborn. And for patient 3, they only have a band, a distinct band forming in this region, okay? So this is likely to be someone with hemoglobin S, okay? Even though we know D and G can migrate, these are less common hemoglobins. So if you find one here, it's more likely to be an S than any of the others, okay? And then the next patient has a band in hemoglobin in the A region as well as the S region. So this person has sickle cell trait, that's an AS. And then the last one is a band in the S and then the C region. So this person has hemoglobin S and C. So they have sickle cell disease SC. So that's how the interpretation for hemoglobin electrophoresis is done. That's how it's done. Okay. Okay, so this is just to show the citrate agar. That's the other electrophoretic method. But as I said, we'll not be dwelling on this much. Okay, so let's have a simple exercise. So anybody can unmute themselves and then provide an answer. So this is another electrophoretic shoe. This is actually how it looks like. It's not very nice, distinct bands. Okay, this is the control sample, the number 1. So these are the sample wells or the patient's numbers. And this is where the bands will form. So this is a control sample. So control sample has all of them, A, F, S, and C. Okay, so patients 2, 3, 4, 5, 6, 7, and 8. Okay, so the first question, which of these patients has got sickle cell disease?
Patient 4.
4.
Okay, so I can hear patient 4. Okay, so
Patient
patient
4.
4.
okay. So patient 4,
Patient
4.
4.
Patient 4.
okay, thank you.
Patient 4 and 7.
Okay, thank you.
27.
Let me proceed. Please
Patient
unmute
4 and 7.
4 and 7. So please mute yourself. Okay, thank you. Kindly mute yourself and then let me just go on. All right, so yes, I do agree patient 4 and 7 have sickle cell disease. And the reason is that patient 4 has a band only in the S region, okay? And patient 7 has bands in the S and the C region. So that's an SC, and this is likely an SS. Okay, so we are correct. Okay, so now the second question, which patient has sickle cell trait? Okay.
Patient 8.
6 and 8.
Patient 8.
6
Okay,
and 8.
okay, so 6 and 8. So it looks like we get the whole idea of hello.
Hello, I can hear you. They were muted.
We can hear you, ma.
Okay, great. All right. So yes, so I agree. Patient 6 and patient 8 have AS traits or sickle cell trait because they have bands showing in the A and S regions. Okay. All right. I think we've already talked about patient 7 that has SC. So we'll move on. Okay. So after you identify the hemoglobins on your electrophoretic strip, and usually that is what the lab personnel will report as either AA or AS or A or whatever. So the lab person will present you with a result, okay? So what the clinician will do is to interpret that result, okay? And interpretation of results means that you have to link it to the patient that this concerns, or you have to place it in a clinical context. So you don't always carry what has been said and then work with it, okay? It needs to fit into the puzzle, okay? So in the clinical context, what I mean is that maybe the patient has suggestive symptoms. So as I said, patient may be having pain episodes, has low hemoglobin, has jaundice, okay? So that makes it fit, okay? And also a family history. So you need to take a family history because we know it's a hereditary disease. So maybe they may have other members of the family who have the disease, or even if they don't, maybe the parents of that individual are carriers of the abnormal gene, okay? And also you need a full blood count or a complete blood count, looking at the hemoglobin level, the MCV. MCV is what tells you about the size of the red blood cell. And then the MCH, it tells you about how much hemoglobin is present in the red blood cell, okay, or the concentration of the hemoglobin. Okay, so you need to interpret it with all these parameters. And also you may need an iron studies, which is a type of test that tells you whether an individual has iron deficiency or not. And this is because in our setting, iron deficiency is also quite common. So you have someone with low hemoglobin, you want to make sure that this is not due to iron deficiency. So that is how your iron studies will come in to help. And also more commonly, sometimes sickle cell can coexist with thalassemia. So you can have co-inheritance with alpha thalassemia. You can have sickle beta thalassemia. And these variants tend to have low MCV, that is low red cell size, low red cell concentration of hemoglobin, okay? And this can closely mimic or look like iron deficiency. So your iron studies helps you distinguish between the two. And then the red cell morphology, which is your blood film comment test. Okay, that also helps you place everything in the right context before you make that diagnosis of sickle cell disease in a patient. Okay, so I think we've done the interpretation AA, AS, SS. Okay, now we are relating it to the clinical context. All right, so moving on. Anytime you conduct hemoglobin electrophoresis or any hemoglobin separation method that I've talked about, okay, in principle, you need to confirm with another hemoglobin test, okay, to be able to establish the diagnosis. So for instance, if you have someone diagnosed with SS on hemoglobin electrophoresis, you need another testing method, which is not hemoglobin electrophoresis. So you can use an HPLC or you can use an isoelectric focusing to confirm the result. Okay, that is the recommendation. But I do understand that in our setting, sometimes resources may not allow us to use two different testing methods. But as much as possible, if we can, that is what should be done. Okay, so what are some of the advantages of hemoglobin electrophoresis? It provides accurate detection of common hemoglobin variants. It's also widely available in most of our settings. It's cost effective. So compared to the HPLC, the isoelectric focusing, it's cheaper, okay? And also requires less skill or yes, it's more complex to run HPLC. You need someone who has a higher level of skill to do HPLC compared to HB electrophoresis, okay? However, it can be used to direct clinical management It's also useful in testing people who require genetic counseling, and it's useful in family studies as well. Now, what are some of the disadvantages of hemoglobin electrophoresis? And then the first one is very important, especially in the newborn period. You cannot use hemoglobin electrophoresis to test a newborn or to diagnose a newborn with sickle cell disease. So we don't use this in a newborn screening program. And this is because in the newborn period, as I mentioned, you have very high levels of hemoglobin F, and sometimes it can mask the other abnormal hemoglobins like the S or the C. So it may not give you a good representation of what the newborn has. So avoid it in the newborn period or in people under 6 months. Okay. Another disadvantage is for patients who have recently been transfused with blood. So once someone has been transfused, it means that you have introduced the donor's red cell into their system, and in effect, you've introduced new hemoglobins into their system. So once you run the electrophoresis, you may find some hemoglobins that may not be representative of what the patient has. Okay, so you have to be careful in a patient who has been transfused and you've ordered a hemoglobin electrophoresis. You have to interpret it in that context. So usually you expect that you repeat this test maybe in 3 months' time when the donor cells may have may no longer exist in the individual. Okay, and it's unable to, another disadvantage is that it's unable to differentiate some hemoglobins, especially those that migrate together. So you remember I said that S migrates with D and G. So sometimes it's difficult to see that this is S or this is D or this is G because you're in the same band. So you may need a second type of test to be able to resolve those areas. Okay, and it cannot detect alpha thalassemia. Okay, and in the case of beta thalassemia, it's more of an indirect way of helping, because in beta thalassemia, they tend to have a high A2. Remember I said usually your A2 should not go beyond 3%. So if you see anyone with high A2 levels, it raises your suspicion for someone who could have beta thalassemia. Okay, but you need to go further to order additional tests to help resolve this. Okay, but of course DNA analysis comes in to make things easy. So it's spot on in diagnosing the thalassemias, the alpha and the beta thalassemias. Okay, so what is the role of hemoglobin testing in genetic counseling? Okay, so it helps us determine who is a carrier, who has the disease, and it can help us guide family planning decisions. Okay, it can help people make informed choices, especially when they know their genotype. Okay, and it helps identify at-risk couples, so couples who are likely to have children with sickle cell disease or any hemoglobinopathy, and this can help in the counseling of these couples. And the most important for me is it reduces the sickle cell disease burden through prevention. So the only sure way to avoid sickle cell disease is prevention. And once you know your status, or once you know your status, you can make an informed choice. And if you make the choice of not going with a partner that potentially can bring up a child with sickle cell disease, that is the sure way of prevention. Okay, so in conclusion, hemoglobin electrophoresis is critical in screening and diagnosis of sickle cell. And when you are using it, you have to use it in the right context. Remember, you should always place it, have your clinical assessments, family history, and then also the confirmatory testing that I talked about if you can. And it plays a very important role in genetic counseling and helping people make that informed choice that they need in planning their families and then also choosing their partners. Okay. Thank you very much.
Thank you very much, Dr. Ahmed. We are really grateful for the lecture. Quite an interesting journey on laboratory diagnosis of sickle cell disease. Please, if you have questions, you can place it on the chat box for Dr. Ahmed. Questions before we move to the next lecture? Any question for Dr. Ahmed? Please place it on the chat box. Any question for Dr. Ahmed? Kindly place on the chat box. Thank you.
Can we give them time to think about it while I go ahead with this very brief presentation? And maybe by that time, questions will be ready for us. Is that okay?
Yes, Prof. Yes, Prof.
Okay, please let me know if you can see the slide I'm trying to share. Please, are you able to see it?
We can see your slide, ma'am.
Okay, shall I go ahead?
Yes, yes, ma. You don't want us to introduce you?
Go ahead if you have it. I don't know whether you got it or not, so you can go ahead if you want to, so that after that. Otherwise, I have Friday next week. You can do the introduction next week, Friday. Okay, good morning, everyone. My name is Pris Agyeman. I'm a professor of adult health nursing and the Dean, Faculty of Nursing, the University of Ibadan. I'm going to be giving us just very brief overview of genetic counseling this morning, and then we will continue next week, Friday, to deep dive a little bit into it. But let me say a very big thank you to Dr. Ahmed. I was in the last set, and I was truly excited, and I look forward to having her this morning. Thank you so much for the clarity of your presentation. And please do stay around for us to see if the participants will have come up with their comments and their questions at the end of this. So thank you very much. As a way of introduction, there are so many conditions that are caused by mutations that are passed down from parents to their offsprings. And so I have a visual summary of different genetic conditions that have genes involved, and there are various mutation types. Like what I have here now, the top on the list is sickle cell disease, because that's what we're focusing on, and that's what we'll be looking at. And that is why genetic counseling is becoming a very prominent profession. In other parts of the world, genetic counseling is actually a standalone profession where you have people in biological sciences who get their master's degree in genetic counseling. In our environment, we don't have the luxury of that. And so one of the aims of this is to stimulate our appetite, to whet our appetite, to begin to make us to think, especially if you're in the biological sciences. We are health psychologists, we are nurses, we are social workers, we are health educators, we are people who work with human population. And it's very important because it is an issue that we have been with since I was born, and every one of us. And today, it is still the same, especially in our countries, the countries of the participants on this platform, Nigeria and Ghana. So that means that we are still not getting it right. Something has to be done. And honestly, I can make bold to tell you that if you have, competent genetic counselors who are able to occupy the rightful position, it's going to go a long way in influencing all of these inherited genetic conditions, especially sickle cell disease, which is our focus for this morning. Others are cystic fibrosis, Huntington's disease, Tay-Sachs disease, Duchenne muscular dystrophy, phenylketonuria, Marfan syndrome, hemophilia, female hypercholesterolemia, thalassemia, BRCA-related cancers, and so on and so forth, just to mention a few. And these are all the genes that are implicated and the mutation types that you have them. So it's becoming really topical, it's becoming very popular, and many people actually go into this field. So the essence of the presentation is not to make us genetic counselors, no, but to whet our appetite, to motivate us, to ginger us to begin to look at this relatively new field or new discipline and see if there are a few of us who will be interested in actually taking this on. So as a way of introduction, Dr. Ahmed has made my job very easy with her presentation. It is an autosomal recessive pattern, which according to what we have been told, both parents must carry a copy of the gene for their offspring to develop the disease. So when you're talking about genetic counseling, there's one very old definition by Reed in 1975. And it was reported in 1965. Sheldon actually, came with this definition in 1947. So you agree with me that it's really quite old. But as old as it still resonates today. In several places, several quarters, several textbooks, you will see the definition of genetic counseling is still coming from the takeoff or offspring or offshoot of Reed 1975, which Reed Sheldon Clark actually brought up in 1947. He's a biologist, a geneticist, and he has been credited to be the person who formally introduced the concept of genetic counseling. So what is it? This is the definition of American Society of Genetics in 1975 that I said, yes, old, with very old roots and genealogy, but still sounding an alarm today and is reflecting in several textbooks of genetic counseling. One key word is that it is a communication process, and communication is very important. In every societies and cultures, communication is very, very important and what they represent. So it's a communication process, number one. And this, in genetic counseling, the type of communication process we are talking about is the one that deals with, that is the second point, human problems. It's not a zoonotic ideology. It's the aspects of communication that deals with human problems. So the first thing is, it is a communication process. Number two is that it deals with human problems. But these human problems are the human problems that are associated with, and this is the third vital element in this definition, associated with occurrence or risk of occurrence of a genetic disorder in a family. So whether it is actual or potential, actual means, sickle cell disease, as an example of a genetic disorder, is already there, or there's a potential of it being there. So American Society of Genetics, 1975, defined genetic counseling as a communication process which deals with human problems associated with the occurrence or risk of occurrence of a genetic disorder in a family. And by extension, in this case, we'll be talking about sickle cell disease. So in a nutshell, it is a two-way interaction, and it's quite different from the typical advice giving that we know, according to Agyeman et al. In 2020. You do not give advice when you are counseling. No, it's far away from it, because everyone needs to be able to take decision. So traditionally, it is non-directive, because the counselor go ahead and provides correct and current information, which will position the client, enable the client make an informed decision. So the actual active ingredient is informed decision. And this informed decision is according to a patient's preference. And this client or patient is going to make his or her preference. It's going to be based on information that is correct, information that is correct and balanced. So when the genetic counselor has provided this information, it positions this person in a very vantage position to be able to make a decision that is informed. And that is why It is not, it is different from advice giving. In genetic counseling, the goal is to empower individuals and families to be able to make these informed decisions about their health, as well as reproductive choices, by ensuring that they have been given comprehensive information about sickle cell disease or any genetic condition we are looking at, as well as available options. Dr. Ahmed mentioned some things that, you can make reproductive choices. To be able to make those reproductive choices means that you know the decision, the choices you want to make, you have good understanding of what they are, the pros and cons, all of them at your fingertips. And so the genetic counselor has to do all of that work such that the power is transferred to the patient. It is not how good you are as a healthcare professional. It's not how excellent you are as a doctor, physician, a surgeon, a nurse, or whoever you are, or a psychologist, or a pharmacist, or public health expert. What is important is how skilled are you in transforming the empowerment capability to the client or the patient. In this scenario, this person is confident about making decisions. There's no doubt or any shadow of confusion in any way as far as the patient is concerned, because you, as a healthcare professional, you have transferred the empowerment to that patient. And that is the goal of genetic counseling. And what you do includes things like reviewing the history of the patient, both family and medical histories. When you get that information with which you are able to draw the family pedigree, we'll be looking at that on Friday next week, God willing, then you are able to explain the inheritance patterns and formulate risk factors or identify the risk factors. Then it becomes easy to offer guidance for the individual to make informed choices about genetic counseling, genetic testing, disease management, curative options, preventive strategies, and so on and so forth. So genetic counseling really has a fantastic goal. There are key aspects of genetic counseling. The first is education and information. Remember, this individual you are dealing with must be confident about making an informed decision. Also remember, you as a healthcare professional, you must be able to empower this individual. So genetic counselors help to explain genetic conditions. Whatever the genetic conditions is, which in this case is sickle cell disease, all of this empowerment and all the presentations, all the PowerPoint delivery, all the experts that have been speaking with us are to help us acquire this skill, to be able to understand sickle cell disease, understand the autosomal nature of sickle cell disease, understand the inheritance pattern of sickle cell disease, and then be able to understand testing options. We've just heard about electrophoresis. And fantastic, I watched Answer. I've actually unmuted everybody. And I was hearing the answers to that question. Those three trained teasers that we were given. Fantastic. So it is no longer the more you look, the less you see. When you see that table well, if you see those kind of films and tables and slides, you have an understanding. You can put human face to the slides. You can attach human face to the blood sample that is withdrawn. And that is fantastic. So as a genetic counselor, the education and information component is a key aspect that will enable you to offer explanations about sickle cell disease or whatever genetic condition we are dealing with is, including inheritance patterns, and then, of course, genetic options and available management and treatment strategies. Apart from that, you have individual and family risks that are there for passing on a genetic condition, and you are able to see that once you obtain the family history. That's why the family history is important. You are able to see the family tree. And medical history is also important, so you also assess that. And if applicable, if the individual has obtained genetic test, it illuminates the differentials. It makes it very clear that it's likely to be this or that when you have the genetic test result with you. Apart from education and information, very, very important is support and counseling. Take it from me. There's no basis providing education and information that leaves your client or patient devastated and then it ends there, or you leave him or her hanging. No. So it is important to be able to provide emotional support, be able to address psychosocial concerns, and then help individuals and families adjust to whatever the consequences or the implications of the genetic diagnosis or the risk, whatever they are. It's very important that, so we're all reading the table and interpreting it there. But you know this is theoretical. It does not stop there. If you were to have a live patient before you, you don't just say, number 3, the patient has sickle cell disease, and then so you are SS, you have sickle cell disease, congratulations, have a wonderful day. No, we all know it doesn't go that way. So to provide the support and the counseling, the emotional guidance, all that accompanies that, the psychological issues, the social issues, the concerns that this individual has, and so on and so forth, are all embedded in this. So that you can, not just empower the patient to be able to make an informed decision, but you are also there to provide the support that is necessary. And if need be, sometimes you can actually refer to other support groups that can be of help and assistance. There are some people who are already formed themselves into a support group with the goal of synergy in supporting one another, so that if that person demands or requires or will not mind to be in a larger support group where others who are experiencing sickle cell disease are, and learn about their coping strategies and other opportunities that are available to them, depending on the status, the class, the educational background, religious status of the person. You can also get materials, resources for the person to read if the literacy level accommodates that. So the person reads a lot of materials and you're available to answer questions when that person raises questions. That is part of support for this individual, and that is another key aspect of genetic counseling, because the education you've provided, the information you have given, and the support that you are ready to render following the sequela of whatsoever the client is presenting is what will actually give that person the backing, the strong backing, the confidence to be able to make that informed decision. So you help this individual make informed choices about genetic testing, treatment options, reproductive options, family planning, for example, and so on and so forth. And the person is sure that, yes, as at now, where I am, this is the best decision I can take, given all that I'm surrounded with. And then another key aspect is collaboration with healthcare professionals. Genetic counseling is one beautiful discipline that brings out the beauty of collaboration among healthcare professionals. Genetic counselors, they work with other people like doctors, like nurses, like psychologists to provide comprehensive care. So that these days you have mental health professionals involved. It could be one thing or the other that psychologically is wading in, and then the mental health professionals are able to do an excellent job there. And the person can actually develop very stubborn, for example, venous ulcer, leg ulcer, or any kind of ulcer. I'm just giving that as an example. And then you will need a professional in that area. It's not just a physician, but somebody who understands and who deals and specializes in wound, area. You could also have either psychologists, psychotherapists, all in that area of dealing within the psychological milieu to help assist in taking out time to respond and deal with some issues that may be showing up or coming forth from this person. Apart from myriads of other things, you could have financial issues and you could have family issues, and the social workers become very important in dealing with that. So there's no other discipline where the beauty of collaboration manifests than in genetic counseling, because genetic counselors work with other healthcare professionals to be able to provide comprehensive care to the patient. So who are the people that need genetic counseling? Individuals, couples, families, and so on. Whoever is concerned about possibility of passing on a genetic condition to their offspring, whether the person has been diagnosed with a genetic condition, or there's a family history of a genetic condition, or the person is undergoing prenatal testing, or considering some forms of reproductive options, or genetic testing for various reasons. Very important is indications for genetic counseling. If there's an abnormal prenatal test result, or unexpected amniocentesis, or inherited or birth defects, or if a woman has 2 or more miscarriages or stillbirths, or if a woman is above 35 years old. And as a genetic counselor, there are certain attributes that are very important to have. For example, you must be a very patient person who is kind and compassionate. Some people, generally speaking, are always in a hurry. They are always rushing, even though they are not Russians. They are in Ghana and in Nigeria. They are not in Russia, but everything about them is always fast, 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 shift, 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 move, 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 speed, 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 and they are not patient. You may, honestly speaking, need to go for a reframing or a retraining. Otherwise, you have no business with genetic counseling. You must be patient to listen to your client. You must be kind to empathize, and you must be compassionate to take actions. So you must be a people or person who enjoy working with other people. If you just like your life, you like your space, you're not in for genetic counseling. But if you enjoy working with others, fantastic. And you're a good communicator, take notes, and a good listener. I repeat, a good communicator is different from being a good listener. There are some people who are very excellent communicators, although adherent inside good communication skill is good listening skill. But I've come across a few people who are extremely good listener. I mean good communicators, but they are not good listener. And it's a skill that needs to be learned. Somebody is drawing on my slide. Please stop so that I don't have to go off and come again to reshare my slide. So you must be a good communicator. You must be an active listener, not a passive listener. You must be someone who enjoys the beauty of listening to others. Some are wired for that, some are not. If you are not, you can reprogram yourself. You can even be intentional about learning it. For example, if you have young children or grandchildren at home, you can tell them to tell you a story and time yourself and make sure you do not interrupt them. Allow them to continue to talk. Don't say, so what is the essence? Or so? Also, what is the conclusion? No, don't say. Just allow them to go ahead and tell you whatever they want to tell you, and time yourself and see how many times you resisted the temptation of bumping in and just listening to everything that has to be said. You are building your listening skill. Or you are a wife or a husband, you can choose your spouse and say, honey, how was the office today? Can you tell me all that happened from the time you drove out of this house to the time you returned? Generally speaking, men are not good talkers. You can just tell, the man can say, oh, I had a hectic day today, and that's it. But if the other way around, you ask your wife, oh, tell me what that happened today. From the time you left this house till you return from work, you will hear a lot. So if you make up your mind, you want to be a good listener, you want to learn the skill of listening, then you're not going to interrupt your wife. You allow her to talk. I continue talking. Oh, honey, when I left the house this morning, You didn't see what happened. Oh my goodness. In fact, as I drove out, it's God that saved me. In fact, I don't know how I slammed the brake. Somebody just came from somewhere and just was about to cross the road. Can you imagine? I don't know how my brake. Okay, your car is automated brake system. Oh, maybe that was where it just stopped. You know, she has not left the house. She's still just driving out of the house. In fact, she can start from the house about how she navigated through the gates and how she nearly, hit the gate, but somehow. So you will hear, for a long time, you will hear. And if you are able to keep quiet, don't say anything, don't bump in, except you want to say, what? Really? Seriously? And to encourage her to continue telling you the story. And when she's done after 30 minutes, then you know that, oh, good, you have done well today. And if you cannot, no problem. If you stop after 5 minutes, I say, well, no, I'm not doing it again. It's okay. Thank you for your story. Then you know that you have not gone beyond 5 minutes. Another day, you start again, another topic, another theme, and you stretch your time and see if you can go for 7 minutes and so on and so forth. And you continue to build your listening muscle until you are practically able to listen to anything from anyone if you choose to. Then you must be interested in the sciences. Hey, don't be a storyteller alone. You must be able to understand mutations. You must be able to understand inheritance patterns. You must be able to understand penetrance. You must be able to understand, autosoma, and so on and so forth. The science behind all of this are very important. And finally, you must enjoy helping people. Some people they just derive pleasure in helping others. They go arm's length, they go, beyond the normal call of duty to say, oh my goodness, you mean, okay, how can I be of help? And then if I cannot help you, you know what? I can make a reference. There's a group or there's a professional. So all of these are embedded in the fabric of counseling. And that is why so many professionals in our context can fall in line and can actually help to be able to get this done within the purview of their professions. And that's why I said this is to actually whet your appetite. This is to stimulate you to say, okay, this is one thing I want to do. And there are so many courses online for genetic counseling, which are free, you can take. Some are paid, you can take. And there's master's degree programs in genetic counseling in Ghana, in South Africa, and in so many European countries and the US and Canada and foreign countries that are offering genetic counseling at master's level. And if you are interested, honestly, I bid you welcome into all of that. And there are certificated programs also. So there's an algorithm in genetic counseling. Generally speaking, there's initial assessments with your goal at gathering information and providing as much information according to the level of understanding of the person before you about sickle cell disease. Then when you have succeeded in doing all of that, you want to obtain history that will help you to draw construction, family pedigree. So you're able to construct the pedigree. And then you will come up with risk estimation, which will be jotting at you once you're able to do that. And then you can communicate and take necessary action for screening if necessary. Whether you're dealing with a carrier, a prenatal situation, a newborn screening, actual diagnosis, and so on and so forth. And if you have results, you can do disclosure of results. And when you have disclosed, oh, this is SC, this is SS, this is AS, this is AC, this is whatsoever it is, then you can address the concerns and available options. Then decision making is vital. Remember, it is the person's responsibility, not yours as a counselor, to make informed decision. And the linkage is specialists. And then, of course, you follow up after your referral. So essentials of genetic counseling include history, whether family history, medical history, social history, all the histories, obtaining them, and be able to tease out the useful information to draw the pedigree, and then conducting clinical examination for differentials, and then confirmatory diagnosis where need be. I heard Dr. Ahmed telling you that You can't just rely on electrophoresis. You may have to do HPCL. And we all know that is costly, but it's important to do a confirmatory diagnosis. And some people will go and be doing the same test in 2-3 different places without actually doing a confirmatory test. And the calculation of recurrence risk and potential risk, and the counseling with available options and follow-up. All of these are vital ingredients and essentials of genetic counseling. In conclusion, and in summary, I've been able to tease you and whet your appetite in preparation for next week Friday presentation and all the other presentations we have. Excuse me, please. The use of genetics in clinical care has increased. Excuse me, please.
We can. Oh. Unmute yourself, ma. Unmute yourself, ma. Unmute yourself, ma.
Okay, thank you. Can you hear me now?
Yes, ma. Yes, ma. Unmute. Ma, unmute yourself. Yes, we can hear you now.
Okay. Sorry about that. Sorry. So the use of genetics in clinical care has increased, raising both interest in and concern about the impact of genetic information on the life of individuals and families. So as the scope is expanding and involving patients, professionals, community health education, educators, and so on, all of this we are doing now becomes imperative, and that is the whole essence of this training and this capacity building. Thank you very much for listening, and over from me. Thank you.
Thank you very much, Professor Pris Agyeman. Thank you for that overview on genetic counseling. We really appreciate it. We thank you for giving us the introduction, the history, the indication, attributes of a genetic counselor, the essentials of genetic counseling. I want to remind our participants that Prof said you don't advise. You only empower the clients to make informed decision and choices about their health and reproductive health concerning the genetic conditions, risk, and other options. And also, as a genetic counselor, you are expected to be patient, kind, compassionate, a good listener, wonderful communicator, people-oriented, and you must be interested in science, because science is the backbone of all we have been talking about since yesterday: genetic, inheritance, all what we have done today in sickle cell disease is all about science. Permit me, ma, to briefly introduce you. Please, the person that just spoke to us now is no other than Professor Pris Agyeman. Professor Pris Agyeman is a leading Nigerian nurse, medical sociologist, and academic, currently serving as the Dean of the Faculty of Nursing, University of Ibadan, Nigeria. She holds dual master's and PhD degrees in nursing and medical sociology from University of Ibadan, with advanced training in nursing classification and cancer genetics from the University of Iowa and University of Chicago. Professor Adjemon's career breeds clinical practice, education, research with notable contributions to the genetic counseling of non-communicable diseases, including sickle cell disease, stroke, and cancer. She has been pivotal in integrating genetic counseling services into healthcare systems across Nigeria and Cameroon. Her global impact includes consultancy for WHO on COVID-19, preparedness across 8 African nations and co-leaders of National Institute of Health FIC D43 Spark Train project. Inducted into the Sigma Theta Tau International Nurse Researcher Hall of Fame in 2022. She's also the founder of the Focusing on Young Nurses Initiative, FYNI, fostering early career nurse development through mentorship and training. With over 120 peer-reviewed publications, Professor Adjeman continues to shape interprofessional healthcare education and practices across Africa and beyond. And also, she's one of the principal investigators for this training that we are having. She's truly a big fish, a mentor, a researcher, an academic, a nurse, a sociologist, a genetic counselor. I can go on and on. Please, ma, we are delighted, we are excited, we are happy for you to come and give us an overview of genetic counseling. Thank you very much, Professor Priska Olabisi Adjeman. Thank you, ma'am.
Thank you so much.
So we have another lecture today before we conclude for the day. Our lecture is on newborn screening, career screening, and testing by Professor Obiageli Nnodu. Mr. Aaron. Mr. Aaron.
Maybe you can introduce her while we are waiting for
Okay.
the talk. Can you introduce her?
Okay. Let me, as a way of introduction, Professor Obiageli Nnodu, LNC for Sickle Cell Disease Research and Training, University of Abuja, Nigeria. Professor Obiageli Nnodu is an adult hematologist, director, Center of Excellency for Sickle Cell Disease Research and Training, University of Abuja, and a national coordinator, Consortium of Newborn Screening in Africa, CONSAC. Principal investigator, SPACO, Nigeria. Abuja coordinator, Sickle Gen Africa, Co-PI, UK, NIHR, Patient-Centered Management of Sickle Cell Disease in Sub-Saharan Africa. MPI, Managing Sickle Cell Disease through increased adoption to hydroxyurea in Nigeria. Accelerate and Quartet PI for D43 Spark Train. Nnodu has led multi-institutional, multinational research projects. She serves as an expert on non-communicable diseases to the Federal Ministry of Health and international agencies, including WHO Afro. Her assessment of the level of implementation of the WHO Afro strategy in sickle cell disease in sub-Saharan Africa, high burden. Let me take it again. Her assessment of the level of implementation of WHO Afro strategy in sickle cell disease in sub-Saharan Africa high burden countries highlighted the need for increased global funding for sickle cell disease. She led the screening and prevention session of the Lancet Hematology Commission on sickle cell disease. Professor Nnodu is the special advisor to the coordinating Minister of Health and Social Services of Nigeria, that's the Nigerian coordinating Minister of Health and Social Services on sickle cell disease. So this morning, we'll be having Professor Nnodu speak to us on newborn screening, which is one of the major researches that is going on to improve sickle cell care and management in our country. Thank you.
Mr. Aaron, over to you.
All right, man.
Thank you.
Please, can you hear the voice or the audio?
Not yet. I can see the slide, but
We
I can't
can
hear.
see the slide, but no audio yet.
Mr. Aaron, not yet. We can see the slide, but no audio.
All right. I'm looking at it.
All right. Well, please just give us a few minutes so that the audio can come up.
Meanwhile, if there are questions, they can start putting it in the chat so that the questions can be answered while we are waiting for Mr. Aaron.
If you have any question for Dr. Ahmed or Professor Friska Adejimo, please quickly drop your questions on the chat box while we try to fix this.
Been nicely set by good
Yes, thank you.
evening,
We can hear it now.
everyone. I'm delighted Thank you very much to the organizers for inviting me to make this presentation. And I'll be speaking on newborn screening for sickle cell disease. So the background has been nicely set by Dr. Eunice, whom I share a first name with, from the Kwame Nkrumah University. She's an adult hematologist. So I'll be speaking on newborn screening for sickle cell disease. And this is a very important subject. So I'll be using the following background: what it is, why it's important, the protocols that are available, the delivery systems, how feasible and acceptable newborn screening is, what are the challenges to the implementation of these programs in our subcontinent, what are the possible alternatives, and how we can go beyond pilot projects to national newborn screening programs. And then I will be talking about the role of genetic counseling in newborn screening. I'm sure that some of you who have been on this course for the past 3 weeks have had enough about the epidemiology of sickle cell disease. We just know that this is a problem that is growing in our continent because of the high birth rate within the continent. And we know the morbidity and mortality that this poses to babies that are born in the continent, such that majority of them will die before their 5th birthday, and more will even die if they are poorly managed and they are not able to attain adulthood. And so for people who want to deal with other disease conditions, if within Africa, if they do not pay attention to sickle cell disease, the countries will not be able to attain their SDG goals for the countries. And it's also important for us to know that it's not just the under 5 or the infants, but that sickle cell disease is a leading cause of mortality in youths and in adults, below 50 years of age. So this slide is very important, and it tells us about the basic interventions for us to control sickle cell disease. One is raising the public awareness, newborn screening, which is our topic for today, and there's at primary healthcare centers, not just when they come into hospital, having a registry of patients with sickle cell disease so that we can prospectively follow them up and carry out surveillance for complications, and then we can intervene. Then establishing prophylaxis for infection, pneumococcal vaccines, oral penicillin, the use of insecticide-treated bed nets and anti-malarial treatment for those who have sickle cell disease early enough, having a health maintenance, and at primary healthcare center. You notice I keep talking about primary healthcare centers because this is a way that we can achieve universal healthcare coverage for our population, and then making sure that they have access to comprehensive care. And of course, the topic, the reason we're having these webinars is because genetic counseling is very important for those who have sickle cell disease, as well as those who are carriers. And genetic counseling should actually target this if we can do anything about reducing the prevalence of sickle cell disease. Nutrition is important. Education of patients and caregivers is very important, to know what to do in acute conditions before coming to the hospital. And something as simple as optimal hydration, is some of the things that we teach them. But newborn screening itself is a 6-part system, which includes education, screening, short-term follow-up, diagnosis, management, and evaluation of the program. And normally when we talk about newborn screening, it's the whole host of conditions that are tested. But here in sub-Saharan Africa, because it's a very high prevalence, we are majoring on sickle cell disease, thalassemia, and other abnormal hemoglobin variants. I know that some countries are also talking about including congenital hyperthyroidism and glucose 6 phosphate dehydrogenase. So, what is the evidence, that newborn screening works? In the most of them have come from the US, and one study in sub-Saharan Africa. We have these studies in the 70s and 80s were able to tell us that babies who have been screened have early have been able to survive when they're identified at birth. More have survived than when they're identified in early childhood. And babies who received pneumococcal vaccines have significantly lower invasive pneumococcal disease. And then babies who also have received oral penicillin have been able to do better, and they are less likely to have a fatal bacterial infection. And those who have received hydroxyurea therapy and those who have received surveillance for risk of stroke and blood transfusion when they are at high risk, these babies have been able to do better. And that is the justification for urgent universal newborn screening systems and increase access to sickle cell disease treatment. So it's not enough, to screen. If we get them at birth, then we have to give, from birth to 5 years of age. These are the interventions that we want to make sure that they have daily penicillin, anti-malarials, full exposure to vaccines under national immunization programs, and add-on vaccines of PCV 23 and meningococcal vaccines and boosters, and hydroxyurea nutrition, just like I said. But education of the caregiver is very important, and the resources are there available within our healthcare systems to do this. Dr. Eunice has talked about diagnosis of sickle cell disease, so we didn't bother too much about it. But one thing I want to say is that these cellulose acetate electrophoresis is not the method of choice for newborn screening because of the high level of fetal hemoglobin that makes it less likely to detect the low levels of hemoglobin S in that period of life. So we want to use other modalities like isoelectric focusing, high performance liquid chromatography in the public health space. And then in research, we can use molecular studies. In recent times, because of the challenges of implementing newborn screening in African countries using standard test methods such as HPLC, which is very expensive, isoelectric focusing, which you need a lot of skill for, supply chain logistics, people have come up with very sensitive, low-cost point of care tests. And there are the front runners, the sickle scan and hemotype SC. And recently, we have the Gazelle, which also quantifies the level of hemoglobin, separates it into those fractions that Dr. Eunice was talking about, so that you can know exactly how much of A, how much of S, how much of F, C that is there, and A2. So these are very important progress that we are seeing. But the good thing about the point of care test is that it doesn't require electricity, and you can get it really at the point of care. So when can the diagnosis be made? We are looking at prenatal diagnosis, through molecular studies. We are looking at the newborn period, and we are looking at post newborn in infancy and teenage. Of course, throughout life, diagnosis for sickle cell disease can be made, and the method will depend on how much infrastructure is available. But one thing about the point of care test is it can be done even in remote areas, and you don't need so much training to be able to do that as IEF and HPLC. So we need to pay attention. So I sent this Lancet hematology article defining global strategies to improve outcomes in sickle cell disease. That was the Lancet Commission that was came out a few years ago. So it's very important reading, and I want anyone here to look at the section on screening and prevention, and it's very pertinent to our discussion this evening. So what are the approaches to screening? So we look at the available technology, we look at the evidence of benefit, and we look at the disadvantage and the challenge that it has. So for mostly we are using heel stick. Rarely do people use cord blood. I know in some countries they go that route, but for the most part it's a heel stick and is very accessible within the public health space. So we're having a isoelectric focusing, HPLC, capillary electrophoresis, mass spectrometry, and point of care tests. So you can see that electric focusing is widely implemented. It has there's extensive experience with it. It's beneficial. The benefit has been abundant. The program, HPLC and capillary electrophoresis are used in newborn screening programs in the UK and France. It has a high cost of equipment and reagents. Mass spectrometry is been touted that it can be used where you have labs that do a heavy bacteria work, but it's very high cost, and it has extremely high throughput if anybody is able to get one in there. But point of care tests have been successfully implemented in newborn screening programs with evidence of benefits in Nigeria, in Haiti, in Ivory Coast, Ghana, Martinique, and the Gambia. And it was Dr. Adegoke that actually carried but it's not enough to have newborn screening. Every counseling can be done by people who are trained for it, and the test results should be recorded in the road to health chart. And then, of course, confirmatory testing should be done, and the mothers of positive babies who fail to collect the results can be tracked by the nurses in the immunization clinic, and then the results should be consistent. The results should be consistent. The newborns with results consistent with possible sickle cell disease should be appropriately referred, even when they don't want to go. So I'm talking about this now from the point of view of the care that is required to set up newborn screening programs. It must be embedded into existing public health program for the screening and follow-up. And the programs that are available in our countries are the immunization clinics, the maternal and child care program, malaria control, the PEPFAR program for HIV. And these are very important established programs that we can integrate newborn screening into. And so for each program, before you set up, you have to define where the samples will be collected, when the samples will be collected, the screening laboratory, the test to be used for the screening and confirmation, what happens to the results, the persons responsible for to follow up the patient and to schedule clinic visits, and where the confirmatory testing, when and where it will be conducted, and the clinical network for follow-up and care of screen detected babies. So all of these have to be planned, and then of course the data, has to be carefully acquired and stored and then used for a program. So for the Federal Ministry of Health, there's a policy for newborn screening, and the protocol for newborn screening that was established, and the government has 6 newborn screening centers in these locations you can see on the map. But because they were based on high performance liquid chromatography, they didn't really go too far. And then this is a protocol for the Consortium on Newborn Screening in Africa by the American Society of Hematology, and that is being demonstrated in 7 African countries, as you can see on that map. But if you look at a newborn screening in African countries, we see that most of them are using isoelectric focusing. Isoelectric focusing in Nigeria, in Liberia, Burkina Faso, Kumasi is the oldest one, Republic of Benin, and Senegal, Dakar. This is by PearFab Foundation. And this paper that really looked at it and described the programs in each country was in 2020, but last year they also had an updated current status of newborn screening with DBS worldwide, a comprehensive review, which you can look for and read. So anytime you see this kind of thing, it means there's a lot of interest in the topic. So many people are writing. So there's more than enough material. Each of them pilots a newborn screening. So what we want to do is, how can we go beyond pilots to have a national scale up of newborn screening programs? So I'm going to briefly describe 3 attempts to do this. One is the demonstration project by the American Society of Hematology Consortium for Newborn Screening, which was is a consortium within a collaboration between American Society of Hematology and African hematologists, like I said, in those countries. And it's just to demonstrate the effectiveness of newborn screening and early therapeutic interventions for babies with sickle cell disease in sub-Saharan Africa. Excuse me. So the consortium was able to negotiate lower equipment and reagent costs for newborn screening on the IEF platform. The other one is initiatives to enhance newborn screening using point of care tests. I think we kind of led this work based on when we did some evaluations of the 2 frontline point of care tests, which we published, and then a lot of countries have also done similar work following. But this was based on the SparkNet with the PIs. These are picture of when we did the hemotype SC, and we launched, the study was well publicized. So we tested across the 6 zones of the country, the 2 point of care tests, sickle scan and hemotype SC. Then the third one is an initiative by the Sickle in Africa. So Sickle in Africa is a consortium that is in 6 African countries with a data coordinating center in South Africa. So we were looking at, we did this work, implementation science work within the Sparkle grant, where we had established a disease registry of over 34,000 patients in 6 countries. And so we wanted to find out how we can scale up newborn screening. And the method was exploratory, sequential, mixed method of assessment on the use of 3 technologies to facilitate newborn screening for sickle cell disease. In the preliminary phase, we evaluated the performance characteristics and cost of DBS point of care tests compared to standard POCT and isoelectric focusing and HPLC. Then in the quantitative phase, we screened 7,500 newborns across the 6 countries with DBS POCT. And DBS POCT, DBS is common to each of the standard methods, IEF and HPLC. And then in the qualitative phase, we conducted focus group discussions and in-depth interviews for all the stakeholders that are involved, the healthcare workers, the mothers, the policymakers. And the reason we did this was to assess the barriers and facilitators for DBS POCT newborn screening. And the screening was done within existing public health programs such as immunization clinics in primary healthcare centers to explore the ease of integration of newborn screening into these services, because we wanted to see how to scale it up. So the summary of what we are getting from these stakeholders is that the parents and caregivers want the sample to be collected in postnatal wards and immunization clinics, and they wanted more education for parents and outreach to communities with information to alleviate fears and misconceptions about newborn screening. While the policymakers felt that the significant barriers to implementation include parental reluctance, inadequate training for healthcare workers, financial constraints, particularly for families in hard-to-reach areas. With the recommendation that to overcome these barriers, we need to increase awareness, we need to increase the training for healthcare workers, we need to integrate screening into existing health services, and we need to ensure that there's government support for training and resource allocation. And so, for the healthcare workers, the key benefits to newborn screening include early diagnosis leading to better health outcomes and improved life expectancy for affected children. And they felt that parents were more likely to accept point of care testing due to minimal blood requirements and quick results. And then they also felt that they should be given incentives. I don't know how that can happen, but people are used to aid. So they want incentive for mothers to bring their babies for screening and for follow-up. Overall, everybody knew that collaboration with community leaders and existing health programs is essential to enhance the reach and effectiveness of newborn screening initiatives. So the challenges that we have found in this area is that the interventions are not readily available. There's lack of acceptance of results of screening, and there's loss of follow-up across the 7 countries of babies detected in newborn screening. And so there's a need to integrate into existing public health programs. And also, we are really looking at how to scale so that those in remote villages can have access. So follow-up is very essential in identifying. So after identifying the babies, we must ensure that they are followed up. Post-test counseling needs to be done. We have to enroll them into the prophylaxis for infection. We have to confirm the testing and genetic counseling, not only to families with the disease. HBCC is not really considered to be a disease, so they need to be told that. But those with the trait, we need to focus attention on those with the trait. So education and training, both for parents and healthcare workers, very, very important, and linkage to pediatric parent support group and other support groups. Enrollment of babies into centers who can provide comprehensive care, and their primary health care centers may be more practical, as have been told to us by the mothers. So how do we deal? So some of the questions that we're still asking is the challenge of parents who are not willing to accept results when the babies look normal within the first 6 months. And how do we deal with babies who are lost to follow up? How do we have difficulty in tracking babies with no house address? And we are fashioning ways of doing this. So IEC materials are important, and this can be shared via social media, and we need to generate awareness. We are trying to do that by engaging the media. We are trying to create demand for newborn screening by patients, and we are trying to create awareness on the need to follow up. So we are giving these messages. Come, the screening is free, but you need to bring your baby for follow-up. So we are also trying to look further upstream in pregnancy. So what is the innovative approach? That is use of point of care technology. So we have tested this. We have implemented newborn screening using point of care technology. We have seen that it is feasible, and we feel that an approach with point of care in PHCs linked to clinical centers will be a good way of scaling up a newborn screening. And we feel that a multi-stakeholder engagement is required to achieve universal coverage, especially in high-budget countries. Looking at the private public health practitioners, also the public, looking at sickle cell disease NGOs, the ministries of education, the media, and the community. So what are the lessons that we have learned? There's a low uptake of enrollment following screening. I think the most that we have gotten across the countries is not up to 70% yet. There's a loss of follow-up, which is a major setback, and then denial of results by mothers because the babies look normal at first. And so we have to sensitize the population to accept screening and follow-up. We need to tell them that the babies will look normal at first, but they have this disease, and they need to be followed up for early intervention. So genetic counseling. So these are the people that we need to target. Babies who are AS, babies who are AC, those who are SC, and SS. And we have this kind of cards that we give out. We write so it has genotype. You can see the genotype is is in quotes, because it's not really genotype, it's a phenotype. So we have the name, this is the information that we put. We say who has done the counseling, where is the health maintenance center, which tertiary hospital is this child linked to, which support group is this child linked to. Then we give the phone number, like a helpline. And then we want to synchronize the information that we are giving out by this simple flyer, that just explains what it is, how it is diagnosed, what happens after diagnosis, and what happens when parents refuse. So my take-home message is that sickle cell disease is a genetic blood disorder in high prevalence in sub-Saharan Africa, leading to early mortality. Newborn screening with evidence-based intervention saves lives of individuals with sickle cell disease, but countries have to make budgetary allocation, and multi-sectoral partnerships is necessary to achieve universal newborn screening in high-burden countries. A combination of standard methods such as IEF and HPLC in reference laboratories with point-of-care tests for remote areas may be required in order to implement universal newborn screening in African countries. Newborn screening should be followed by genetic counseling of parents with positive results. So keep an eye on the tray and the disease. And I wish to acknowledge the support of our university, the Federal Ministry of Health, the Teaching Hospital, American Society of Hematology, PECINELMA, who has been able to make sure that these 7 African countries have lower equipment costs and reagent supply, and then the Primary Healthcare Board, into which we are working, in 25 primary healthcare centers. We are doing the screening in Abuja. And then, of course, our funders, the Fogati International center that gave us this training grant to do this, and the staff, of us. So I want to thank you for listening, and we'll take the questions at the end. Thank you.
Thank you, Professor Nnodu, for that beautiful lecture. It's quite explanatory, expository, and educative. She took us Professor Nnodu is like a timber and caliber when it comes to sickle cell disease, both in West Africa, Africa, and globally. It was quite a beautiful lecture there. At least our take home is that I remember yesterday somebody was asking, what are the scientists doing to help those with sickle cell disease? At least this is one of your answers: newborn screening. Though Professor Alex also answered it and mentioned newborn screening. So now you can understand what newborn screening is all about. Professor Nnodu took it stage by stage, little by little. She dissected it so that we actually understand what newborn screening is and the role it has played to advance sickle cell disease care and management. And you can agree with me with what they have achieved so far, both in SPARC train facilities, in SPARCO, in CONSA, that the burden of sickle cell disease is being reduced. And also, as we are being trained, or as we are having this workshop, we can now understand why we should have interest in genetic counseling with respect to sickle cell disease. Because you can see now, you need to, those parents, especially parents of the newborns who have been found to be positive in that either the child genotype or phenotype is AS, SS, SC, AC, they need to be cancelled. And that's where genetic counseling comes in. And I'm also happy that we also had a JARA today, which is overview of genetic counseling. You can see how all these things are making the training quite interesting. So if you are in doubt whether you are in the right place, I'm sure by now, with everything that happened this morning, from Dr. Ahmed's lecture to Professor Priska's overview of genetic counseling and the capping now of Professor Nnodu on newborn screening, you can never be in doubt why you need this training and why you should continue after this preliminary, because this is a preliminary. Remember that Professor Adejimo told us that this is just a workshop. It doesn't make us a genetic counselor, but you can see that genetic counselors are needed to advance sickle cell disease care and management in our environment. This training is just to whet your appetite so that you know we have this, we need more of these genetic counselors in our healthcare facilities, in our society, everywhere we need it, especially in sub-Saharan Africa, where we have this burden of sickle cell disease in our environment. And also, now you know the attributes of a counselor, sickle cell genetic counselor. I believe that after this training, you want to get more training and advance your training so that you can actually be a genetic counselor. Thank you very much for this, for everything we have heard this morning. And we cannot thank Professor Nnodu more. We cannot thank her enough for taking our time to give us this lecture. Professor Priska, thank you. Dr. Ahmed, thank you. Professor Priska.
Yes, thank you very much. I was just looking through the chats. If there is any question from anywhere that has not been attended to. Mr. Aaron, I sent some information on the platform for your attention. Please check. Okay, but I'm wondering why there are no questions from this group. The other group, we had too many questions that we could deal with, but this group, no questions. Okay. If it is
Ma?
that, I said no question from this group, it either means that we are
Actually, there was a technical fault. I
okay.
think the chat box was disabled. I don't know what happened, but I've notified Mr. Aaron. I'm sure maybe he's trying to fix it. That's why we didn't have any questions on the chat box. Then for
Okay.
those of you asking for attendance, the attendance pool has been launched again. Please try and fill and submit the attendance sheet. It's very important. It has been launched again on the chat. Please fill and submit the attendance sheet. We are so sorry about the chat box being disabled. It's being Mr. Aaron
I
is
think
trying to
somebody,
look at.
I'm trying to see, I think somebody sent me a question. Maybe when the person could not I'm sorry, just a minute. I just want to make sure that okay. Okay. It's a very long question. Okay, this person said that, I think it's for Dr. Agyeman, that a couple, they actually did the test that showed that both of them are AA and they are okay. The husband is a known AA and the wife went to do a test before continuing with the marriage and it turned out to be AS. But because the husband was AA, she didn't mind, she went ahead. And they've been married for a few years, they didn't have a child. So they just got pregnant and they are so excited and happy. But now they went to do a test and the test says that the woman is hemoglobin SS. So they said her diagnosis is newly diagnosed hemoglobin SS in pregnancy. So she's this person is a psychologist and is asking, how possible is that since they've done the test and the test said that the husband was a known AA and the wife was known AS, and she did confirmatory tests, everything to be sure of where she was. He now said that the results that they said she's a newly diagnosed hemoglobin SS person. They said there is a marked elevation. That's why I say it's very long. So Dr. Agyeman, I hope Dr. Agyeman is still in. He said there's a marked elevation of hemoglobin A2, which highly suggests presence of a non-S hemoglobin variant. So hemoglobin E and hemoglobin LaPo, and then elevation of hemoglobin S was seen. So I think what this person is worried about is how come the person did confirmatory test, did test everywhere, and it was confirmed she was AS because she was particular of making sure that she was compatible before getting married. And now she's pregnant. They are now saying she's hemoglobin SS. And she has also done this test repeatedly, confirmatorily. He's saying she's AS. So if Dr. Agyeman is in, can you please answer this person?
She's in. I've asked her to unmute.
Okay. That's the only question that was sent to me.
Okay. Yes, so I'm here. Yes, so this is a very tricky one. A husband who has hemoglobin AA, a wife who has hemoglobin AS. That was prior to her pregnancy. And in pregnancy, it's been determined as hemoglobin SS.
Yes.
We would have to review this scenario. So I don't know what testing method was used. Remember, some of the testing methods have downsides or have limitations. So I don't know what testing methods were used. and who ran the test, who interpreted it, whether these were done correctly, because otherwise it doesn't add up. But in this case, it has to be studied again and probably repeated with a test that does more of quantification. So maybe they should repeat a test if it was not done with maybe an HPLC or an isoelectric focus, and that should be done for her now, and establish her actual sickle cell phenotype. And then we can work our way backwards and then see what the husband is. Well, I think the husband's own doesn't really change her genotype, but maybe her AS that was initially diagnosed could have been an error, or maybe the SS that has been diagnosed now is rather the error. So we'd have to look at those two scenarios, either see the test, what was used, and then reanalyze, or probably repeat the test to be able to settle the difference. Thank you, and over.
Thank you. I believe the questioner has had the answer, and if he gets back again, I'll let you know. Thank you very much. I didn't see any other question, so we are going to close. Thank you so much for your time. We appreciate you. Over to you, Dr. Oriaku.
Thank you, everyone. We appreciated the organizers on behalf of the principal investigators, our facilitators and lecturers, and the organizers and the local organizing committee of this Spectrum Genetic Counseling in Sickle Cell Disease workshop. I appreciate all of you for waking up very early in the morning, Ghana 6 a.m., Nigeria 7 a.m. to join. We have really, you can agree with me that today was just extraordinary. But this is just a tip, because this training continues next week. We still have 2 more weeks to go. This week is just week 2. 2 more weeks for the online training. Then after the online training, the last day, we'll have our post-test. After that, people will now be selected for 2 weeks hands-on at the various sites, Ibadan, Abuja, and Kumasi, Ghana. So please continue to attend the lectures. It's educative, it's impactful, it's insightful. It will help you both as a healthcare provider, professional, and caregivers. And also it will help you to help your society. With the knowledge you gain, you should be able to educate people around you on what to do and how to go about it. Because people might, our societies as Africans, we have neighbors, we have relatives. They will come to you to ask questions. I believe you have more understanding, scientific understanding, to answer some of those questions that they ask. Thank you, and God bless you. Have a wonderful weekend. By God's grace, we'll all meet again Friday, 8 p.m. Nigerian time, 7 p.m. Ghana time. Thank you. The attendance is still there. For those that have not filled it, please quickly fill the attendance sheet before this meeting ends. Thank you very much. Professor Priska, over.
Over. Thank you so much. So let's quickly go to our various meetings and let everybody go and enjoy their weekend. So we can meet now at the debriefing session so that we can quickly meet. Thank you so much, all our speakers and all the distinguished participants. Have a wonderful Saturday morning and enjoy a restful weekend. Bye.
Bye. Thank you, ma'am. Bye. Bye, everyone.